Hello my dear students, welcome on this session. In the previous session, we started discussing the gastrointestinal system and we already started discussing peptic ulcer and we discussed few groups of the drugs useful for peptic ulcer. Let me show you the slide from the previous presentation. Once again, we started classifying the drugs. We said the drugs are anti-H. pylori drugs. This includes the anti-H. pylori antimicrobial agents. Have a look at the slide: amoxicillin, clarithromycin, tetracyclines, metro and tinidazole. And amongst the anti-H. pylori agents itself, I added proton pump inhibitors and colloidal bismuth subcitrates because these drugs have got their own action, that's proton pump inhibition, and the colloidal bismuth subcitrate its own action. But still, in addition, they have got an anti-H. pylori effect. That's why I put them under anti-H. pylori drugs. Then the second group was the drugs decreasing the gastric acid secretion, and we had H2 blockers, proton pump inhibitors once again appearing here because they decrease the gastric acid secretion, anticholinergic drugs and PGE1 analogs. So what we had done in the last session is we discussed anti-H. pylori drugs including the antimicrobials, proton pump inhibitors and CBS. And we just had started the discussion of the drugs decreasing gastric acid secretion. To complete the classification, we also have ulcer protectives, that's sucralfate and colloidal bismuth subcitrate, and ulcer healing drugs carbenoxolone and sodium, and the drugs which neutralize the gastric acid, that is the antacids, non-systemic and systemic antacids. But the place we had come until was the drugs decreasing gastric acid secretion, and we start discussing the H2 blockers on this session. The H2 blockers, the H2 receptors, histaminergic H2 receptors, is associated with the gastric parietal cell and it's concerned with the gastric acid secretion. So when you use H2 blockers, they inhibit all the phases of gastric acid secretion, that's the basal, psychic, neurogenic and the gastric phases. And H2 blockers are useful in gastric ulcer, duodenal ulcer and stress ulcer. Some other uses includes gastritis, Zollinger-Ellison syndrome and GERD, that's gastroesophageal reflux disease. Which are these H2 blockers? An older H2 blocker is cimetidine, and this cimetidine was used in the past, was a less potent agent with short duration of action. It had another drawback, was it was an inhibitor of the cytochrome P450 enzyme system, and that's why it led to so many drug interactions, because the drug inhibited the metabolism of many other drugs. The next important adverse effect or the drawback of cimetidine was it binds to androgen receptor and it leads to various sexual dysfunctions in the form of gynecomastia, galactorrhea, impotence, decreased sperm count and sterility in the females. So gynecomastia, galactorrhea, impotence, decrease in the sperm count, and the females, it led to sterility. Next, it also crossed the blood-brain barrier and produced the central nervous system adverse effects, and alcohol intolerance was remarkable with cimetidine. So the use of cimetidine gradually came down by the time we had the newer H2 blockers. The newer H2 blockers are more potent, obviously, than cimetidine. They are long-acting agent, so you can give them once a day or twice a day. They don't produce any hepatic microsomal enzyme system or cytochrome P450 enzyme system inhibition. So the chances of drug interactions are fairly less, and fortunately they don't have anti-androgenic adverse effects which cimetidine had. There are infrequent central nervous system adverse effects expected, but newer H2 blockers also, just like cimetidine, inhibit the alcohol metabolism, the acetaldehyde metabolism. And this is why when the patient is receiving H2 blockers, the newer H2 blockers, the patient should not consume alcohol. The drugs under this category are ranitidine, famotidine and nizatidine. The next group of agents which can decrease the gastric acid secretion is anticholinergic drugs, because that's the muscarinic receptor site at the gastric parietal cells, that's the M1 site. Which are the anticholinergics which can do this? There's pirenzepine, that's a specific M1 blocker, and you have others which include propanthylline, methanthyline, oxyphenonium bromide and many other agents. The next group of drugs which decreases the gastric acid secretion is prostaglandin analogs. And as you know, prostaglandin E1 has cytoprotective function. It decreases the acid, it decreases gastrin, it increases the mucus and bicarbonate. So it produces a cytoprotective effect, and the PG analogs which can be used in peptic ulcer are misoprostol, rioprostil and enprostil. What's their use? They could be used in high risk patients to prevent the NSAID induced ulcers. And I hope you understand the non-steroidal anti-inflammatory drugs, the NSAID, they decrease the prostaglandin secretion. They decrease the prostaglandin synthesis. So this patient becomes more susceptible to peptic ulcer. That's one of the commonest adverse effects of the NSAIDs. So you could think of using the prostaglandin itself or the prostaglandin analogs for high-risk patients to prevent the NSAID-induced peptic ulcer. The problem with the PG analogs is you need to give them frequently, and they also produce toxicity. This could be diarrhea, abdominal cramps, uterine bleeding and abortion because they are uterine stimulants. So these are the drawbacks of the PG analogs. Ulcer protectives which are available are sucralfate and CBS. And we already made a comment about CBS when we discussed it on the last session. What is sucralfate? Sucralfate is a drug which should be given before meals, and it should be given for 4 to 8 weeks. Sucralfate is aluminum salt of sulfated sucrose. It's a disaccharide. It has got astringent effect, means it precipitates the superficial proteins, it combines with the dietary proteins and produces a physical barrier or coating on the ulcer, and it gets adhered to the ulcer base. So what happens is a physical barrier, a coating protecting the ulcer so that this ulcer doesn't get irritated by the noxious stimuli. So we are calling this drug as ulcer protectives. These drugs, that's the sucralfate, this drug stays at the ulcer base for a fairly long time. That's the long stay at the ulcer base. That's more than 6 hours. In addition, this drug delays the gastric emptying and is also known to stimulate the prostaglandin synthesis, which could offer some cytoprotective effect. So we are discussing an ulcer protective which will be astringent, will form a precipitate, will form a physical barrier or coating, and will get adhered to the ulcer base so that the ulcer is protected. We move further to a very important drug interaction of sucralfate with other drugs. I am showing it to you on this slide. Please have a look at the slide, and I am also telling you some important fact about sucralfate. So let's concentrate on the slide. What's this drug interaction and why it's happening and what's the reason? See, sucralfate is a disaccharide, right? So if it has to become active, if it has to start its action, it has to get polymerized and has to polymerize to bind to the ulcerated tissue. Okay, so you want a disaccharide to get polymerized. If this is to happen, sucralfate needs low gastric pH. It means the pH of the stomach should be low, then the disaccharide can easily get polymerized and go into the another form, that's polymerized form, and then get bound to the ulcerated tissue. Now what happens is, in a patient with peptic ulcer, we are enthusiastic to decrease the gastric acid secretion. And if we want to decrease the gastric acid secretion, what is going to happen is the gastric pH is going to change. The pH is going to increase. Which are these drugs? One, H2 blockers. They will increase the pH. Next, antacids, which will neutralize the acid. Next, the proton pump inhibitors, which are going to decrease the gastric acid secretion. So see what happens. It's very interesting. You want to keep the gastric acid secretion low, so you give those drugs which will decrease the gastric acid secretion. But what's going to happen is it's going to raise the intragastric pH. And when the intragastric pH increases, sucralfate cannot get polymerized. Unless it gets polymerized, it cannot bind to the ulcerated tissue. So if you decrease the gastric acid secretion, leads to increased pH, and then it is like antagonizing the action of sucralfate. So we need to be careful using sucralfate, H2 blockers and sucralfate, antacids and sucralfate, proton pump inhibitors and sucralfate is going to lead to opposite effect, or rather your sucralfate is not going to be active. So that's the important drug interaction. We move on to the next group, and that's ulcer healing agents. Ulcer healing agents. And the name of the drug is carbenoxolone sodium. It's been given a special place, and it's called not just ulcer protective, it's called ulcer healing agent. What does it do? Number one, it increases the mucus secretion and it increases the lifespan of the epithelial cells. That's great. That's a novel mechanism. We don't know the exact way of doing it, but it's been found to increase the lifespan of the epithelial cells. And when the lifespan of epithelial cells is more, this is going to promote healing. So we call carbenoxolone sodium as an ulcer healing agent. Does it lead to any adverse effect? Yes, it's a steroid-like structure. So it produces steroid-like effect. And the steroid-like effect is a mineralocorticoid effect. That's sodium and water retention leading to edema. So it could aggravate hypertension. So we need to be careful if your patient is suffering from cardiac diseases. If the patient is suffering from hypertension, then we could not think of using carbenoxolone sodium. In addition, it is known to decrease the serum potassium, so there could be hypokalemia. So that's about the ulcer healing agent, carbenoxolone sodium. So now we are coming to the last group of the drugs useful in peptic ulcer, and these are antacids. First we discuss the non-systemic antacids. They are magnesium hydroxide and aluminum hydroxide. This is your most common combination used in practice, used in day-to-day life as an antacid. Magnesium hydroxide plus aluminum hydroxide. I am calling it non-systemic antacid because these drugs are insoluble and they are poorly absorbed. They are not going much to systemic circulation and they are going to produce local action. A chloride salt will be formed if these drugs combine and react with gastric hydrochloric acid. Come to the slide and concentrate on the slide. On this slide, I have written a reaction of magnesium hydroxide with gastric hydrochloric acid. So let's read it. Magnesium hydroxide plus 2HCl is going to lead to formation of magnesium chloride, that's MgCl2 plus 2H2O. So if you look at this reaction, you understand what's being formed is the chloride salt. This is what I said. And water. What about magnesium chloride? Is it going to get absorbed in the systemic circulation? No. Magnesium chloride is poorly absorbed. It's a non-absorbable substance. Let's think about the second substance, the second antacid. The second antacid is aluminum hydroxide and it's written as AlOH3. Now if it's AlOH3, it will combine with gastric hydrochloric acid. So let's have the look at the reaction. AlOH3 plus 3HCl leads to formation of AlCl3 plus 3H2O. So what's formed? Water and aluminum chloride. Again, it's a chloride salt of aluminum. Is it going to be absorbed? No, it's not going to be absorbed. So what we are saying is, at the end of this reaction, there is no net addition of positive ion to the systemic circulation. And because it's not adding any positive ion, for example sodium, to the systemic circulation, and it's producing only local effect, we are calling it non-systemic antacid. I hope this concept is clear why we call it non-systemic antacid. Why do we combine magnesium with aluminum? Aluminum salts produce constipation. they decrease the GI motility. And the magnesium salts, they produce diarrhea. If you use magnesium alone, it will be an antacid, but it's going to produce diarrhea. If you use aluminum hydroxide alone, of course it will produce the antacid effect, but it can lead to constipation. And to counter these effects, because fortunately they have opposite effects, you can use them together as aluminum hydroxide plus magnesium hydroxide. So that becomes a very popular combination of a non-systemic antacid. Next we discuss the systemic antacids. And the systemic antacid is sodium bicarbonate, NaHCO3. And have a look at the slide for the reaction. NaHCO3 plus HCl is going to form NaCl, that's sodium chloride, and is going to remain with H2CO3, that's carbonic acid. This H2CO3 will further get broken down into water, that's H2O plus CO2, carbon dioxide will be produced. So this is sodium bicarbonate. Now if you look at this reaction, what is formed after combination with hydrochloric acid is NaCl, and that's sodium chloride. I hope you're going to appreciate this. When is the formation of sodium chloride is going to be readily absorbed to the systemic circulation. So once sodium enters the systemic circulation, it's going to produce alkalinization. And because there is net addition of sodium to the systemic circulation, we are calling this drug as systemic antacid. What's the use of the systemic antacid? It's used for systemic alkalinization or for production of systemic alkalosis. It's extremely useful as a systemic antacid in those situations in which you face drug overdose with weak acids. That's barbiturate poisoning, acute barbiturate poisoning, there will be severe acidosis. In acute salicylate poisoning, there will be severe acidosis. Tricyclic antidepressant overdose. Tricyclic antidepressants are weak acid, so you can get tricyclic antidepressant overdose. This is also going to produce acidosis. There are more situations like diabetic ketoacidosis. There are more situations like alcohol intoxication. All these situations, you can use sodium bicarbonate by intravenous route of administration to produce systemic alkalinization. And as such, it doesn't have a place in the management of peptic ulcer. So that was the discussion about the systemic antacids. After we discussed all the drugs, just a few words about Helicobacter pylori. This H. pylori, the organism which is implicated in the pathology of peptic ulcer, pathophysiology of peptic ulcer, is a gram-negative organism, and in 20 to 70% of individuals, it is a commensal. It can promote the back diffusion of hydrogen into mucosa. So there will be factors due to which this commensal, which is present in 20 to 70% of individuals, will start producing this effect, and there will be back diffusion of hydrogen into the mucosa, and this will be responsible for causation of peptic ulcer. Helicobacter pylori is implicated in the pathophysiology of chronic gastritis, in the pathophysiology of peptic ulcer, dyspepsia, and carcinoma of the stomach. Just a few words about the peptic ulcers which we see today. 90% of the peptic ulcers are either due to H. pylori or they are due to non-steroidal anti-inflammatory drugs. So 90% of the ulcers, they have one of these causes, H. pylori or NSAID induced peptic ulcer. Anti-H. pylori triple regimens in peptic ulcer have been really useful to help these patients. So what are the triple regimens? We already discussed in the beginning of the peptic ulcer when we introduced the topic. We said we have to intensively treat the H. pylori and we have to keep the gastric acid secretion low. So there is a trend to use 2 antimicrobial agents to hit this H. pylori. In addition to this, you add 1 proton pump inhibitor. So 2 antimicrobials plus 1 proton pump inhibitor. The first regimen which is used in peptic ulcer is called OCA and is given for 7 days. What is this O? Have a look at the slide. O is omeprazole, 20 milligrams 2 times a day. The second one, C, is clarithromycin. It's 500 milligrams 2 times a day. And the third one, that's A, is your amoxicillin. A large dose of amoxicillin, 1 gram, given twice a day. I think it should be easy to remember. Dose of omeprazole, standard dose is always 20 milligrams. Clarithromycin is always 500 milligrams. And amoxicillin for peptic ulcer is 1 gram. All of them are given 2 times a day, and the treatment should last for 7 days. After this, you can continue omeprazole, a proton pump inhibitor, for a total period of 4 to 6 weeks. I hope you know this. So that's OCA. The second triple regimen could be OCM, again for 7 days. Omeprazole 20 milligrams 2 times a day. Clarithromycin 500 milligrams 2 times a day, just as above. And your A, amoxicillin, is replaced by metronidazole. Metronidazole 500 milligrams 2 times a day. So again, all the drugs given 2 times a day for a period of 7 days. So I just presented to you some standard regimens, triple regimens for management of peptic ulcer. There is another regimen which is available, is called OBTM, and it's given for 14 days, that's 2 weeks. What is O? O is obviously omeprazole 20 milligrams 2 times a day. Then you have B. This B stands for bismuth subsalicylate. 525 milligrams has to be given 4 times a day. The third one is T, and that's tetracycline, 500 milligrams 4 times a day. And the last M is metronidazole, so that's 500 milligrams 3 times a day. With this, we come to an end of the discussion of peptic ulcer.